So it's time to get started. So, and thanks everyone for coming out bright and early on this rainy Friday morning for this grand rounds. And I'm really happy to introduce Dr. Jeremy Howick from Oxford University. And he's going to talk to us about empathy and about how there's scientific evidence to show its effectiveness and importance for care. But first I just want to talk about, just very briefly introduce Jeremy, his background. He got his PhD from the London School of Economics in 2008. And in a subject called philosophy of science, which you might wonder, how in the world could this ever be relevant to public health? But of course, public health is a really interdisciplinary field, as you all know, and I think this talk will be a great example to illustrate how ideas from different areas can really contribute. And so I think with that, I think I'll step aside and let Jeremy begin. And Jeremy's going to speak for about half an hour, and then Ava, our very own Ava Oberly, will begin and commentary for about 15 minutes.
Can people hear me in the back? Some background information. I'll let you read it. It's not part of my talk. It wouldn't be a real talk if there wasn't some glitch with IT. These are my collaborators. I will thank them before I begin. So I'm going to talk to you today about why every healthcare consultation needs a dose of empathy. In fact, positive empathic communication is one of the best treatments for many common mild to moderate ailments without the side effects. So outline, I'm going to tell you two stories about how I got into this, and then outline the systematic review of randomized trials of positive empathic communication, and then a bit about how this stuff can be implemented. So how I got into this? Well, I used to row, and I got okay at it, and sometimes when things go really well, you get up on the podium and get a medal. And then something really bad happens. They sometimes drag you off the podium and to a toilet and make you pee in a bottle to test if you've taken any banned substances. And some athletes get a positive test, and they say, well, I was just taking the medicine doctor gave me, led to a positive test. That's probably true sometimes, I don't know. But I developed an allergy to a cat my mom got from my sister. And I went to the doctor, and he poked me about 30 times in the arm and said, well, you're allergic to cats and dogs and ducks, which I already knew. And then prescribed a treatment, a nasal spray. And as was my habit, I looked very carefully at the ingredients. One of them was corticosteroid, and that, of course, freaked me out a little bit. I said, well, I can't take this. I might end up getting a positive test for a banned substance. Turns out it's not that nasal spray, but I didn't know. And when I was communicating with Sports Canada in Ottawa, they weren't giving me an answer quickly. They might have thought I was trying to game the system. Meantime, I was suffering, my training was suffering, I was getting more anxious, I couldn't sleep properly. So as a last resort, I took my mom's suggestion to visit a herbal doctor. I said, that can't work, it's going to be rubbish. But I said, I got nothing to lose. I went there, I expected to see crystals and so on hanging around. There was none of that. We just spoke about the stresses of high-level rowing and the allergy symptoms of what they were doing. And in the end, she prescribed two things. One, keep your head and neck warm, which is just a sensible thing to do in Canada in the winter. And two, drink ginger tea. I said, that can't possibly work. But again, I thought, I've got nothing to lose. It's probably not poison. Like in many countries, eat a lot of ginger. If it was poison, they'd all be dead. It's probably one of my vegetables a day. I should eat more vegetables anyway. So I tried it. Within a few days, my symptoms subsided. That got my philosophical mind going. I said, well, is it just a placebo? Was it the fact that she took a lot of time to calm me down? And if it was a placebo, how would we ever know? Can you make something that looks and tastes and smells like ginger tea, but that isn't ginger tea? And then even if you could, there are probably some biomedical scientists thinking, yes, I can do that. Even if you could, there's no commercial interest. You can't patent ginger tea. So here's another story. There was a young boy called Max Gallus who lived about 120 years ago on what's now called Vancouver Island. And he was certain that the shamans were doing some kind of tricks, that they were deceiving people, but he didn't know what the tricks were. So he convinced one master shaman to sign him up as an apprentice. And he eventually convinced one. And eventually a patient came into this apprentice, a hysterical man in wild hysteria. The shaman pinned him down and was sucking on the side of his belly and eventually spat out a bloody clump and said, the demon's gone, you're okay now. The guy was okay, walked out fine. But Max Gallus had been watching. He put some eagle down, some eagle feathers between his lip and his gums, and he'd been sucking on them to make his gums bleed on the eagle feathers. So what the shaman spat out was a clump of bloody eagle feathers. And so Max Gallus was ready now and go expose all these shamans as quacks, but he wanted to finish his apprenticeship first. This is a true story, by the way, as recorded by historians. To finish his apprenticeship, he had to treat his own patients. So eventually, a chief from a nearby village summoned him because the chief's grandson was ill. So he went there, grandson was ill, he tried the eagle feather trick on the grandson, and it worked. And then the chief gave him a shaman's name, Quesalet. So if you read this story, you'll see the name Quesalet. But his name was Max Gallus before that. So we don't need these eagle feathers and magic tricks. But this kind of thing's got me going and thinking, well, how can we help? So I did a bunch of work, on placebos, because these are placebo effects broadly construed, empathy and positive messages. We can think of those as placebo effects broadly construed if we like. I did some systematic review comparing the effects of placebos with the effects of treatments on average. Surveys, most doctors in countries where they've surveyed them have used placebos. Placebos can even work if you tell the patient it's a placebo. And positive messages also work. And the question arose in my mind, I've always had a practical kind of attitude, how can we implement this evidence? You can't go around giving people sugar pills, you run into problems of deception, and you don't want to encourage a pill popping, which is already a big problem, one with too much medicine. So the good thing was there are two components of the placebo effect. Again, empathic care and positive communication. So empathy in the trials that we've looked at involved, they cash it out in different ways, but they all share three common elements. One, understanding the patient. Two, communicating that understanding. And three, developing some kind of action, which doesn't mean a treatment, but developing some action on the back of that shared understanding. Positive communication involves saying, this is going to make you feel better, or you don't need any medication, you're going to get better. In the trials we looked at, positive communication is part of empathy. So patients say that their practitioners are empathic if they offer them hope. I'll get to the special cases where patients have really terrible conditions towards the end. Unfortunately, not all doctors do express as much empathy as patients would like. This is the first systematic review we did that looked at how empathic patients ranked their practitioners to be. We found 64 studies. On average, the practitioners were not as empathic as the norms set by the people who developed the questionnaire. Longer consultations were rated as being more empathic than shorter ones, so more than 10 minutes. The biggest finding, though, was that female practitioners were ranked as being more empathic than males. Many people say that's unsurprising. Generally, we already knew that. But it's been ignored because there's a high variation. And people think it's unimportant. This empathy is just a fuzzy thing which doesn't affect patient outcomes. I'll try to show you the evidence that's not the case. You know, in Australia, USA, and the UK, they were ranked as being more empathic than some other countries. There were no surveys in Canada, presumably because you guys all do it perfectly. You didn't want to make them all look bad. Now we'll get into the kind of meatier systematic review. This is currently under review, so it's called, as you can see, Effects of Empathic and Positive Communication in Healthcare Consultations, a systematic review and meta-analysis. So we searched 6 databases. We used standard Cochrane methodology, 6 databases from inception until last August. We included trials with patients aged 12 years and older in a face-to-face healthcare communication. 2 reviewers did all the independent data screening. We had over 40,000 titles to screen initially. The main outcome measures, we took whatever was the main outcome measure, the primary outcome measure in the trial, and we separated them into physical outcomes and psychological outcomes. And we also looked for harms if they were measured. There were 2 types of trials. One, empathy intervention trials. This is where they take a group of practitioners, randomize them to either receive further empathy training or not. Then they go ahead and treat patients, and they measure patient outcomes. With the expectation intervention trials, they again randomize practitioners to either deliver more positive messages or carry on as they usually did, and then treat patients and measure patient outcomes. So they have to be patient outcomes. It didn't suffice to just measure, for example, whether the practitioner behavior was modified. We wanted to see whether that modified behavior resulted in an improvement or not in patient outcomes. The control group was always usual care, and to minimize the risk of bias, we only used randomized trials. We excluded pseudo-randomized trials and non-randomized trials. And we also did a subgroup analysis where we excluded trials with a high risk of bias. So this is just a taster of the results. Because it's under review, I can't share everything, but I'll give you enough of an idea. 7 empathy trials met our inclusion criteria. All but 1 had a positive effect, and 22 expectation intervention trials met our inclusion criteria. Again, all but 1 had a positive effect. Adverse events, we didn't find any adverse events. I'll show you something about that. So here's I'll give you an example of the typical trials included in the review. Here's a trial by Chassani et al. In France in 2006. They randomized general practitioners to either receive empathy training or not, and the main outcome was pain relief. So they trained 180 GPs enrolled, 84 were trained, 96 were in the control group, and they enrolled 842 patients. Patients who were treated by the trained group had lower pain overall. The bottom line, the top left is where they all started off. They had similar levels of pain, and that's over 2 weeks. The bottom level is, the bottom line represents the pain in the group treated by practitioners who've been treated by practitioners who had empathy training. Here's a typical expectation intervention trial published last year by my colleague Winifred Green in Germany. I chose this one because it included both a psychological and physical outcome. The methods they used, they had 124 patients scheduled for coronary artery bypass graft. They were randomized to what they call the expect intervention, where they were told to have positive expectations about the outcome of their procedure. A control group called support, which is, they try to make it like equivalent of a placebo control. And then standard medical care, what they would have received if they weren't in the trial. The psychological primary outcome was disability 6 months after surgery. using a pain disability score we measured on a 0 to 70. So the results, the expectations, showed significantly larger improvements in disability compared to the other groups. And in the physical outcomes, they had lower levels of interleukin-8 post-surgery. And there was no significant difference in adverse events. Here's a visual. So the line that ends up at the lowest on the right side with a circle at the end of it, that's the intervention group. And so the disability, they began with higher levels of disability, they ended up with lower levels of disability. Here's interleukin-6 levels. Again, the expect group, the treatment group, started off with higher levels at the left side and ended up with lower levels. This is anxiety. We did just to show you that these interventions often have global effects on general levels of anxiety and depression and so on. So again, the expect group had higher levels of anxiety at the beginning and lower levels at the end. Within our review, we did some subgroup and sensitivity analyses. So when we excluded trials that had a high risk of bias, the effect size got smaller, which is what's expected in these kind of things. Usually the bigger and better the trial, the smaller the effect gets, but the effect remained positive. And we also found that empathy and expectation interventions improve patient satisfaction and quality of life by a little bit. How does empathy work, you might ask? Well, there's a few different mechanisms, and more work needs to be done in this area. First of all, empathic practitioners can reduce stress. They can also make more accurate diagnoses. Some symptoms are very embarrassing, and unless you feel that your practitioner is sympathetic, empathic, you might not share those symptoms. And without sharing the symptoms, they cannot make an accurate diagnosis. And without an accurate diagnosis, they can't make a good treatment plan for you. One of my colleagues claimed that he heard of someone who probably died because of lack of empathy. A patient was a smoker, and a general practitioner basically called him an idiot. Why are you smoking? You know it's bad. He went away and only came back when his lung cancer was too serious to treat. Also, only an empathic practitioner can make a value-based treatment. And of course, no matter what the effects of the treatments are, we've got to adapt that for an individual patient. And the adaptation involves understanding what's important to the patient. And an empathic consultation can help tease those out. Expectations, these activate the brain's reward mechanism, leading the body to produce its own endogenous drugs like dopamine and endogenous morphine or endorphins. It also helps reduce stress, which can lower pain and anxiety. These are all so basically empathy and expectation interventions have a small but important effect for many common ailments, pain, depression, anxiety. There are limitations to our review, like there are to any study. First of all, it's hard to isolate these kinds of studies. Empathy overlaps with compassion, for example. Positive messages overlaps with motivation. Interviewing, just for an example. To limit this, we used an explicit, replicable, transparent search strategy that can be used in future studies in this area. And also, we can defend the view that empathy is slightly different from those other things. Although there will be overlap, and that's okay. Also, there was a high degree of statistical heterogeneity. The trial did not include, but because the effect size all pointed in the same direction qualitatively, we were justified in pooling, according to the Cochrane Handbook. There's also insufficient data about empathy training. I'll get into that a bit later. And did not report potential harms to practitioners. Some people say, well, you know, Jeremy, I'm a doctor. If I'm too empathic all day, I feel burned out at the end. However, other ones say, no, when they increase how much empathy they express, their job satisfaction goes up. But that needs to be looked at. There's two questions I usually get, and I'll try to fend those off by answering them before I finish. One, what about a serious illness? You said, okay, Jeremy, these things might work for mild to moderate conditions, like mild pain, mild anxiety, mild depression. What about serious things like this? The patient's going to die, and how can you be positive about that? First of all, even if it's only effective for these mild to moderate conditions, those are important. 1 in 10 people in developed nations have depression, A lot of that is mild to moderate depression. It doesn't need necessarily the drugs, which have unknown effects when taking them for too long. But what do we do in these situations? Well, Atul Gawande, have you read the book Being Mortal? So, he cites empathy is more difficult when someone's got a serious condition. But I think it's even more important. So Atul Gawande quotes a palliative care doctor called Susan Block, who says that expressing empathy in these end-of-life conversations is as difficult as a complex surgical operation. So empathy and being positive won't save these patients. They're going to die anyways. Sadly, it often doesn't happen. My mom died of metastatic breast cancer, and her practitioners were not empathic at all. They made her wait 8 hours in a waiting room, never asked her how she was feeling. None of this stuff would have saved her, but it would have reduced her anxiety and improved her quality of life in the last few months. And doctors only realize this when they become patients. My colleague Rana Aladies just wrote a book. It's up there. She became a patient and realized how, in her words, terrible the doctors were saying terrible things about her when they thought she was, unconscious, and she wasn't. And there are a lot of books like this. When doctors become patient, they realize, whoa, something's wrong here. So in the cases when there's serious ailments, it doesn't cure them, but being able to have a good conversation about what's going to happen, what they can do, give them hope about what they can do, is more difficult, but if anything, more important than it is for the mild to moderate ailments. The second question I get, okay, Jeremy, I don't care if my surgeon's empathic. I want him or her to be able to cut properly. That's absolutely right. So would I. Once I made a decision to get surgery, if I had to, I wouldn't really care if my surgeon was empathic or positive or a nice person or not. I want them to perform the surgical operation effectively. I want to have done a lot of them. That's absolutely right. But what about the decision that leads to taking surgery? Surgery often involves risks. There are often different options. So for example, I was offered knee surgery for some relatively serious cartilage and bone damage. But I didn't want surgery for numerous reasons. It was my values. I wanted that to be a last option. So I needed to know what the benefits and harms of surgery were and what the benefits and harms of an alternative, physiotherapy, were. I chose physiotherapy, but making that decision required a doctor, and thankfully my GP is like that, who was empathic and was able to explain and understand where I was coming from. He also knew that I was probably able to follow the physiotherapy routine, that I was very aware of my body and so on. So I needed that. So the decision to go towards surgery requires empathic communication. Some people, there's Daniel and Richard Susskind wrote a book. They said that the surgeons should do surgery and there should be an empathy specialist who does all these common conditions before that. That's fine. If they can afford to pay for an empathy specialist, great. But until that time happens, they, being empathic with the patients will give them better surgical outcomes. And as that trial I just showed you, when they can convince the patient to have positive expectations, it can reduce their anxiety and improve reduce their disability as well. The take-home message here is positive empathic communication has similar benefits to drugs for many common ailments without side effects, and we should use it. We're offering a course if anyone wants to come, if you want to learn more. And I won't go into very much detail about how you can implement this into your practice, but my hypothesis based on the trials I've seen is that most practitioners can be good at it. It's a matter of understanding that it can help and focusing on it. But here's a system that Helen Reese at Harvard developed. It's empathy. It involves eye contact, using facial expression, posture, not looking towards the screen, looking towards the patient, affect, trying to understand the patient's emotions. We're very bad at understanding each other's emotions. You can just ask. Tone of voice. You can have a friendly tone of voice or a paternalistic tone of voice. Hearing the whole patient, asking not just about what they are there for, but what else they're interested in and how whatever they're there for affects their whole life. And then your response. Again, a key component of empathy isn't just listening and sharing that understanding. It's coming up with a response of treatments or treatment options or the idea they might not need treatment. There are also research implications on the back of this systematic review. We need to know a bit more about what the most empathic behaviors are, the best ways to teach empathy, whether it's cost effective. It might take more time. In some cases, it doesn't take more time. In some cases, there's been a trial where the surgeons sat down beside the patients and took notes compared to remaining standing up. They took the same time in both cases, but when the doctor sat down, patients perceived them to be taking longer. The other question is, how can computers help? On the one hand, they might be able to reduce the paperwork load. On the other hand, some people think, well, computers or avatars can actually be empathic doctors, and we won't even need humans. I'm not sure that that's right, but we've got to address that question. Technology is moving forward, and there are some cases where people actually feel more comfortable with computers. You know, have you had an affair? They're more likely to give an honest answer to a computer, apparently, than to a real human being. So given that in the UK, NICE, and here in Canada, the Canadian Patient Safety Institute claims that empathy is a key component of patient care, in this case patient safety, these research questions should be prioritized, I believe. In the empathy program that I've developed with some colleagues, we're also looking at policy, how to implement our idea that a dose of empathy needs to be included in all healthcare consultations. The other way to change things is to democratize knowledge. So we're looking at policymakers. I've also explained this research in a way that non-geeks like me can understand in a book I've just written that's coming out in Canada in a few months. So we don't need eagle feathers or magic to induce the same health benefits Quasala did. But a key component of modern medicine is the systematic review of randomized trials. These are starting to show that positive empathic communication can have similar benefits to drugs for many common ailments without the side effects. And so we think that every healthcare consultation needs a dose of empathy. So thank you very much.
So our next speaker will be Eva Oberle from CPH.
Okay. Thank you very much. Thank you, Jeremy. That was actually a great talk. It was very fascinating to listen to you explain the power of empathy in healthcare practice, and even this idea, well, how can we teach empathy, and empathy, in broadly speaking, a social emotional skill to healthcare practitioners. So what I would like to talk to you today about is how can we teach social emotional skills earlier on in life? How can we make sure that all children and all youth, by the time they graduate from high school, have acquired the core social emotional competencies they need for a healthy, successful life of well-being? And let's take a step back and see, well, how are young people in Canada doing today? Well, a lot of young people are struggling. About 20% of youth are affected by mental health disorders. Only 1 in 5 actually receive the mental health services they need. And this really only summarizes the numbers for those who are experiencing symptoms significant enough to qualify for a mental health disorder. There's a larger and broader group of young people who are struggling socially, emotionally, behaviorally, in and outside of school, but who do not qualify for a specific diagnosis. Well, this is really important because it is during childhood and during adolescence that developmental trajectories are set. So about 70% of mental health problems in adulthood do actually have their onset in childhood or adolescence. So the question is, this early on in life, childhood and adolescence, what can we do systematically to promote young people with the strength and with the competencies they need in order to thrive in life? And this is what takes me to the topic of social-emotional learning in schools. Well, social-emotional learning teaches core social-emotional skills and competencies. This topic emerged about 20 years ago when Dan Goleman wrote his book on emotional intelligence, and this kind of provided a contrast to, well, yeah, schools are there to teach the academic skills, the reading, the writing, the math, the science, but also, what do we really want to see by the time young people graduate from high school? Well, we want young people to be independent, to make good, healthy choices in life, and to be able to build a life of independence and productivity. And the question, well, what are those skills they need in order to do that? Is it really just the reading, the writing, the math, the science, or are there some other skills schools should be teaching? The Collaborative of Academic and Social Emotional Learning in Chicago has come up with those 5 core competencies that really summarize the field of social emotional learning. And empathy, for example, that Jeremy talked about, would fall somewhere here within the social awareness, perspective taking. So when you think about those 5 competencies that are listed here, these are really broader categories, and a lot of more specific competencies that you might read in the literature would be fitting within there. Well, self-awareness refers to the ability to recognize your own emotions, to understand what you're feeling, and then in the next step to manage those emotions, self-management, self-regulation. This refers to emotions like anger, but also envy, also with strong excitement. How do we manage those emotions in a day-to-day setting in a socially and culturally appropriate way? Responsible decision-making. Responsible decision-making within the general ethical guidelines and general larger cultural norms of a society. Relationship skills. This refers to building positive relationships, but also being able to maintain those relationships throughout life. This also involves young people knowing when to seek help from an adult, and people knowing when to step in when they're a bystander in a situation where someone else is being harmed. Social awareness refers to empathy, perspective taking, and this is really a key one to develop the interpersonal skills that are needed in life. Well, what research has found is that we can teach those skills, and this is also, of course, what Jeremy was talking about, specifically in the context of healthcare providers. But social-emotional learning in schools really starts at a much earlier point, and the idea is, well, why don't we just provide all young people with those skills in a systematic way through the school system where we can reach almost all young people in our society. So social-emotional learning can be taught through specific programs in classrooms, but also through broader strategies in the school setting, like the way the school climate is set up through administrators and leaders in schools. And of course, they're supported by the larger policies and the larger regulations around education. So the idea of social-emotional learning in school is to move away from intervention and move to an approach that is a larger preventative approach. And I just mentioned this, schools are of course an ideal site for health promotion because almost all young people attend school for a substantial part of their day for many years in a row. Well, I want to show you a little bit of support for social-emotional learning. This comes partly from cross-sectional studies, from longitudinal studies, and then also from actual intervention evaluation studies. And I'll skip the cross-sectional studies here for the sake of time, but Mark Greenberg and colleagues, they conducted a longitudinal study that was actually published in the American Journal of Public Health. And what they found was in a group of children who were part of a control group in an intervention study, pro-social behavior rated by teachers during the kindergarten year was actually a predictor of very important health and success outcomes in life up to 25 years later. So what they found was that teachers who rated their children in kindergarten to be more kind, more cooperative, better at solving problems, more likely to help others, these competencies positively predicted outcomes like graduating from high school, completing a college degree, obtaining a full-time job, and those competencies were negative predictors of being diagnosed with a mental health issue, with a mental health disorder, being on a waiting list for public housing, having to attend special needs programs, and also engagement with the justice system. So being arrested and the number of times of having been arrested. So this really was a very important study because it really shifted this idea of like, well, yeah, social emotional competencies are nice and they're sweet and kind, but they're really the soft skills, and I'm not sure how important those are. This shifted really this picture to say, no, these are important developmental health outcomes. This is not just about happiness, it's about health, and it's about very strong health outcomes that matter for society. For example, involvement in the justice system. If you think about the costs for society, if there's a way to prevent young people from ending up in that system later on in life, these are definitely dollars worth spending. A study that was conducted by Caprara and colleagues. This is a study that teachers want to hear, because teachers want to hear, well, if I do social emotional learning in my classrooms, that actually takes away time from the academics, right? And what Caprara and colleagues and also many other researchers have shown now in the meantime is that earlier predictors of early social emotional competence actually positively predict later academic outcomes, controlling for earlier academic outcomes. And we also, part of my dissertation study was that I looked at a very similar study using the foundational skill assessment scores in British Columbia, and we found a very similar finding where we found that the grade 4 FSA skills predicted, of course, later academic achievement, but over and above that, teachers' perceptions of students' social emotional skills and students' own ratings of their own social responsibility in life predicted later academic outcomes. So this is a very important piece for teachers because they want to know that this is going to help them in schools and it's not going to hinder their teaching. And a lot of support comes from empirical studies that really went ahead and said, okay, well, now that we know that there are links between social emotional competencies and later success and health outcomes, how can we know that actually changing the social emotional competencies also predicts a change in developmental health outcomes? There have been probably like several hundred studies done in the meantime that evaluated individual social emotional learning programs. There's a very broad range of programs out there. I'm not going to get into the details of those programs. Some of them focus on teaching empathy, some of them focus on teaching perspective taking through techniques like mindfulness. Roots of Empathy, for example, is a program that has been quite successful in Canada, where babies being brought in the classroom throughout the course of the year with a mother, and children learn about human development, about the baby, but they also learn about perspective taking. What does the baby need? What does the mom need? Well, how are the baby and the mom interacting? So I want to highlight this one meta-analysis here that was done a few years ago by Durlach and colleagues. This is probably the biggest meta-analysis. It's a very important study because they reviewed more than 200 studies. All of those studies had a control group. Not all of them were randomized controlled trials. A lot of them were quasi-experimental studies, but all of them did have control group data and pre- and post-test data. And what they found that students who were part of social emotional learning programs that were implemented with high quality, so implementation fidelity had to be high. Those students benefited significantly compared to their controls regarding mental health outcomes, regarding academic achievement, relationships with peers, relationships with adults, and other positive well-being indicators. So this was really the first meta-analysis that summarized all the research that was out there. And they showed, specifically with academic achievement, that participating in SEL was linked to an 11 percentile increase in academic achievement. That was a big selling point for teachers to take social emotional learning on in schools. And it was also a big selling point for policymakers to say, yeah, maybe we should actually require this at a ministry level. Maybe this should be required for all schools, but then if we require it, how do we actually get teachers to be able to do this consistently and not just have like a one-off program? Well, some would of course argue to say, well, maybe it was just having a program in a school. Maybe it wasn't really about the social emotional competencies here that were being taught. And some would maybe argue, well, maybe this is just a pre-post thing. Sure, at this particular meta-analysis, there was very little data available in the long run following up those children. Well, that's why we conducted a study That was published last year in Child Development. This was part of my postdoc at the Collaborative Academic and Social Emotional Learning. And what we did, we went back to those 200 and something studies that Durlach and colleagues had reviewed, and we said, well, let's go back to them and see how many of them actually have follow-up data and how long do we have follow-up data there. And how can we really try and see if those positive effects stick over time. And so we found 82 different programs. A good portion of those were implemented outside of the United States. Overall, we had more than 97,000 kindergarten through to high school students. And the follow-up effects were assessed 6 months. That was our cutoff. We said it had to be at least 6 months after program completion, up to 18 years. Of course, at the higher end, we had very few studies that actually had data, 15, 16, 17, 18 years after program completion. So most of them were around 2 years after program completion. That was, for most of them, that was the latest follow-up. And what we found was that, in fact, the results, the positive results, the positive effects and benefits of social emotional learning compared to children who were part of the control group did keep up. We found benefits for academic performance, we found benefits for social emotional skills, attitudes towards pro-social behaviors, and we also found benefits regarding conduct problems, emotional distress, and substance use. Now, what was really interesting in this study is that we actually could show that the social emotional competencies that students had acquired at post-test were a positive predictor for those long-term benefits. So that was the first time that we could say, yeah, there's something about the actual social emotional competencies that really spoke against this idea well, maybe it's just having a program in school and it doesn't really matter so much what it is. And what we did in the next step is we went to the programs that had collected data in early adulthood, and we kind of summarized them in a more descriptive way, because it was not enough studies had collected this data to do a proper meta-analysis on this data. And what we found that summarizing these studies, children that had participated in social emotional learning through their schools had benefits regarding high school graduation, college attendance, and we also found positive effects for being diagnosed with conduct disorders, arrests, clinical mental health disorders, high school dropout, and STD diagnosis. And if you think about, well, why would social emotional skills, why would teaching that have an effect on STD diagnosis? And if you think about this, you might want to go back to those actual competencies that are being taught and think about responsible decision making, communication skills. All of this is part of effectively stepping up and knowing how to protect yourself effectively and by practicing safe sex, for example. So what I want to really kind of conclude from here is that social emotional learning is something that not only teachers care about because it's linked to positive academic outcomes, but social emotional learning is also something that is of very high relevance for public health because of later health outcomes, but also because of other outcomes like involvement in the justice system that are outcomes that actually present a lot of costs for society, financial costs. Regarding, is it really worth investing in social emotional learning? There's a study that came out a couple of years ago in the United States that estimated that for $1 spent on social emotional learning, there's an $11 benefit in the long run. And what they did, they reviewed 7 specific studies that had collected this particular follow-up data and had looked at outcomes like high school graduation, etc. And I want to just take 1 minute to wrap this up because I know you're all very eager to ask questions. But the question I want to kind of end with is well, how do we make social emotional learning sustainable in schools? And one great thing that has happened in British Columbia is that the Ministry of Education has actually stepped forward and said, yes, we totally need social emotional learning for everyone. Every child should be taught those competencies, and we also need to move away from saying there's a specific program here, like a one-off in the classroom, but we have to go to more broader strategies. Programs might be part of that, but strategies, embedding this as a whole school model, a whole district model, with having leaders and champions from like top to guide this process and allocate the resources, that is really key. And British Columbia has now revised their curriculum. Last year the new curriculum was launched, or 2 years ago in 2016, and the Ministry of Education curriculum in British Columbia now actually mandates, along with the academic skills, social-emotional competencies are mandated to be taught through schools. So this is really a very important first step, because if it's on there, this is what schools have to address, then that automatically becomes part of a vision for schools and something they have to assess, monitor, and address in the long run. And of course, what I would really love to see is that we start with teacher education. I would love to see that we prepare teachers to implement and foster those skills in children before they come into schools, rather than learning this as they're being a teacher. So the idea is really, how can we start very early on? And maybe Jeremy, for this is also, maybe this is also something that has come up for you, asking how can you also get this sort of empathy training, these empathy programs into the maybe the medical training programs. Possible that that's also something you've been thinking about. So yeah, thank you. I'll end it here. And
So those are really, really fascinating, interesting talks. So we're going to have questions coming from the audience, of course, and also questions from the Twitter feed, which oh, the mic, sorry. Questions coming from the audience and from the Twitter feed. Why don't we start with questions from the audience in the room? David?
So they need my mic.
Oh, yes.
Thanks very much, both of you. I mean, just to comment, David, timing couldn't be better to do this with the schools right now. I think the fentanyl crisis is basically telling us we have to get way upstream. My question is for Jeremy, though, and that is, when I take a look at a lot of my colleagues in medicine, the surgeons, the ICU people, I don't think they've suffered from a primary empathy deficit, but a lot of them have empathic fatigue or distress. Empathic distress, I think, is the psychological name for it. And so they've withdrawn to a certain extent. So you're showing us literature saying that empathy training might work to build empathy in the first place. What about to recover it?
Thanks for that question. First of all, who here is a better than average driver? Put up your hand. Come on, everyone thinks they're better than average driver, but the fact is, if it's normally distributed, only half of you are better and half of you are worse. So many doctors think they're expressing empathy, but the first review of patient surveys suggest that many of them aren't doing it as what they'd like to be doing it. Your question is how to recover it. The way we teach it, I didn't go into this, but it's a kind of a three group model. We've got the patients and the doctors and then the healthcare managers. So it's not just about telling busy doctors who are doing already wonderful work. They get overloaded with work. Here's another training course, do more stuff. We want to address the managers to reduce their paperwork load and use technology as well to free up more time. It's not enough. You can't do it just by adding another training course for busy practitioners. That's only one part of it. We've also got to address the managers, and we've got a course for that too, and changing culture from the first step initially. How to recover it, again, on the one hand, there's what they call compassion fatigue, which is very real for many practitioners. On the other hand, when they do express empathy, a lot of them also say that they have higher job satisfaction. They certainly get better patient outcomes, fewer complaints. So to remind yourself, I think like any skill, it's a matter of reflective learning. And I think we know a lot about that. It's a matter of implementing it. But we can't just point our fingers at the doctors and say, do more empathy, because you're right that they're already trying their best and often just have overloaded with work. Thanks.
There's a question that try to pass the.
I don't need the mic.
You don't need the mic? Okay, one for Jen, go ahead.
Which, sir, people online, we do need a mic. Oh. Thank you. Thanks.
So I'm from School of Audiology and Speech Pathology. I'm also a medical speech language pathologist. So a lot of the people I saw for a very long time were having the worst day of their lives, and a lot of loss. I'm most interested in the component of communicating that you do understand, which is really hard for our students. They get stuck there. They get anxious about how do I authentically communicate that I understand. Do you have any elements or things that jump out for you in your studies about the essential components of that?
Dan's getting his 10,000 steps today. So that's an area where we need more research. So I can tell you what they did in the trials that we've seen. So I gave you one model, the empathy model, another one's keep warm, where knowing a patient. So first is body language. Oftentimes now, in the UK at least, I'm not sure what it's like in Canada, they got to fill these forms out. So the managers are forcing the doctors to look at their screen while the patient's talking. So that's right away not a good way to show the patient you're understanding them. So looking at them, body language, small things like nodding and saying, it sounds simple, but that's a way. But truly understanding someone, if you want to get into the geeky details of empathy, affective and cognitive empathy, I've got one colleague who says we can never understand what's going on in someone's mind, and that, to some extent that's true. But one way to get over it, Helen Reese says, well, we're bad at it, so ask the patient. You think you understand, ask them, is this how you feel? So do you feel open-ended questions? How do you feel about that? Asking the patient.
That check-in.
So the first thing is body language and the way you respond verbally to the patient to show that you're understanding and listening to them while they're talking. And then checking. That's what the affect and the empathy model was. Does that help, or is that too generic? Because it's probably too generic because more research needs to be done there.
But I think instinctively, that's what humans want to do.
That's what we want to do.
And we just have to allow them to be present and give
Yes.
them liberty, the freedom to know that that's a clinical competency for them.
Yeah. And you're right, because in the trials we found, some of the empathy training courses lasted 2 days with professional trainers and lots of follow-ups. Other ones lasted 4 hours. So what we think is that, we have to check this, what we think is that doctors, like you said, they're already, people go into medicine because they have empathy, they care about people. By the vast, vast majority of them. They lose it sometimes. So just motivating them, you know what, this is important, it will improve your patient outcomes, be more empathic. Like if you were to tell you, you already know, you already know what to do, and given the time and the opportunity, a lot of them will improve their empathic behavior without any training whatsoever. That's a hypothesis that needs to be confirmed.
Thank you.
Yeah, I have a question. Thanks, and I mean, in terms of, we're always having this debate, in the clinical world between, being able to have more time with the patient and being able to demonstrate those things. And I'm glad that you're showing meta-analyses and controlled trials that show that there is a definite benefit, because that's very persuasive to some of our colleagues. Question is, has anybody looked at gene expression? And because if the stress response, the pain relief response actually should have a gene expression component to it through chlorophyll-melanocortin and stress response. And yeah, I know this is sort of getting far out and totally geeking out, but is that something that's ever been considered?
Does anyone have? No,
Well, that's I'm not sure. There could be, I don't think there is, though. I'm quite familiar with the literature. They've done brain scans, so there are neurocorrelates they've investigated, but for genetics, I'm not sure. That's a great question. And by the way, if anyone's interested in doing some research, get in touch. Because what you're saying about more time, we've got to look, now that we have the effect size, we can do some cost effectiveness analyses.
So are there any questions for Eva?
Yeah.
Yeah.
Go ahead in the back.
Oh, collected.
Thanks. I'm not sure who this question is for, but it is around, I think of the executive level that often does have to, determine some of the conditions in which healthcare workers are working in. And a senior executive, kind of bragging how the lowest score on the entire executive team was in their empathy scores, which I found curious. And I wonder whether there's been any studies done on, or that you are aware of, on empathy at that level of public, not only of healthcare, but of public health, and how that plays into how we, as the decision makers, actually make decisions, and are we not hearing the same? Because it seems to be a correlate to me at the patient or at the organizational or population level.
So, do one of you want to give this one a shot?
I actually don't know any of the research. Do you know any of that research at that level?
No, I don't know, but what we can say is that, as I said, our model for improving healthcare empathy between practitioners and patients requires that the managers have empathy towards the practitioners, and many practitioners complain they don't. They just load them up with more and more paperwork, and so that's all I can say.
Maybe some
Maybe
research.
comment.
So I want to add a little bit of something here from the work I'm doing, where a lot of research is showing that if you, for example, if you want to teach empathy and those social skills to children, you have to have it as a teacher. But if you want to teach it to the teachers, you have to have it at the administrator level. And so that maybe refers a little bit to your question, that there are those different levels. And if we want to teach it here to the employees or to the children or whatever, it has to also be taught in the higher ranks, and those people have to cultivate it, or they have to have opportunities to cultivate it. Which also means that it has to become a part of the culture, that this is something that is valued and also expected.
You can't have empathy if you don't have boundaries.
Sorry.
Yeah, I did. You actually answered my question, but what I've been kind of noticing is the questions about clinical and your responses are very parallel to what I would imagine you could say about the school setting. And so I thought you might like to comment about that, because I see a lot of parallels in the way the questions are asked. It's just a different setting.
Right. Yeah. No. Yeah. I think I think actually, as I was listening to you talk, Jeremy, I realized that there are a lot of parallels, and the idea of like where can we really basically bring the social skills and the empathy or whatever specific or broader skills you're talking about into the system. And in my case, we're starting at the school, and it's universal for everyone. And in your case, you're really like targeting a specific subgroup. But this is really part of the larger topic of how do we grow a responsible society that is thriving.
Okay, I think we have time for one more question.
Or a wrap-up.
No.
Jeremy.
Yeah, Rabbi, another parallel is that you're talking about prevention, and Benjamin Franklin said an ounce of prevention is better than a pound of cure. So you're talking about prevention for all these things at early level. In a way, empathic communication is prevention for making the wrong decisions, and including going down the wrong path of taking opioids and so on. So we're going to worry about that before chatting more.
That's right.
Great. Well, I think this was a great.
Thank you all.